So I'm Frances Carey, I'm the Regional Director of Finance for Specialised Commissioning North. Myself and Liz are going to do a bit of a double act. So this, we've got 3 slides to talk about some of the discussions that we've started in the North around looking at the development of the accountable lead provider model, which isn't necessarily a prime contractor model. I know a number of providers don't necessarily like the concept of a prime contractor model. And it's very much in the early stages of development. We've heard earlier today some of the discussions around how we move into having lead or network provider models. And so we looked at, actually, from a contractual point of view, how do we get to that point and what are some of the risks and issues that might come out of that. So I suppose essentially by 1819 we would like to look at one area or one service where we've got a contract or a model that looks across one service area, which may cover a number of different providers. And looking at, particularly in 1718, around a pilot, so working with providers on how we might do that from a contractual point of view, but also from a clinical point of view, because even though we might have the contractual relationship in place, there's also something about, from a clinical point of view, actually, how do you deliver those services across a number of providers. Obviously, looking at any of the issues, so for example, data sharing between providers, financial risks, risk management, and I suppose essentially at the end of the day, how do we actually make the contract work for both a commissioner and a provider? So I'll hand over to Liz.
Okay, thanks, Frances. Thank you. Okay, I'm Liz Rogerson. I'm Assistant Regional Director of Specialised Commissioning, and I have specific responsibility for the North Eastern Cumbria. As Frances has said, we have been looking at various options that we might consider and what the issues might be to develop new models of contracting, specifically for specialised commissioning, and as we move into a more collaborative commissioning with the CCGs. We have actually established a small working group project team within the North, which crosses with members from the 3 hubs across the North. And we asked them to come up with some of the issues that they had debated within that group so that we could share that with you today. I think very early on in their conversations, they established that the role of the networks, the clinical networks, and operational and strategic networks, was quite crucial in developing future service configuration within the particular localities, and particularly using these networks as advisors. And thinking specifically, referring back again to the 5-year forward view in our earlier discussions about closing the quality gap through working more closely with the networks. And that whatever model of commissioning or contracting that we actually ultimately end up with, that these factors of, the clinical factors have been taken into account, and form follows function rather than the other way around. Earlier as well, we've referred to the fragmentation of commissioning and the resultant gaps that appeared in some of our pathways of care, and we have looked at one of the things that we absolutely need to consider when we're developing these new models is how we actually develop more streamlined pathways of care, and in particular joining up those gaps to improve the health and well-being gap. In all of our considerations, we've been mindful of the need to deliver care as close to home as possible. So when we talk about lead provider models, or whatever terminology we want to use, we're not necessarily talking about delivery from lead centres. We are talking about the lead of a provider across a service, and with as many parts of the pathway delivered as close to home as possible. And I think we're particularly mindful of this as we're developing ways in which we might improve access for the population to specialised services in more challenged, geographically and economically challenged areas of the country, such as we have in the north within Cumbria, who are currently under a success regime. We absolutely recognise that providers may be nervous around the more traditional forms of prime contracting. And we appreciate the nervousness may arise not only for financial reasons and the perhaps not good history of sometimes of payment between providers, but also about the implications for governance and performance. And we want to endeavour to find a model which actually gives assurance that we will support these providers as commissioners and provide not only support in ensuring that the financial flows happen, but also that governance is in place. So in all of this, what we were actually looking for is some feedback from yourselves as providers. This is very early thinking. And we were sharing some of these the issues that we've considered at this stage, so that you can help to shape our thinking and contribute to the development of future contracting models, which may not necessarily be one size fits all. We accept that there may not be one model which fits all services and all provider configurations. We've talked about the performance metrics. One of the things we're conscious of, again, something we've referred to earlier, is that it's absolutely critical to get the right information systems in place, both that they operate with consistent data sets, so that data sets can effectively be compared and talk to each other, but also that we have confidence in the data that is produced. So on to some of the options that we have considered. There are more than two options, but I think they probably fall into two main categories. One would be something similar to the formal lead provider model and operate through subcontracting by the lead provider to other providers. But we would hope to incorporate more formal use of the networks to support our commissioning, and actually to set some goals on performance and procurement. The alternative model, if you like, would be along the lines of an alliance model. Not necessarily a pure alliance model. Again, this is something which, although there are good examples of alliance contracting in different parts of the world and different industries, it isn't a concept that is fully tested within the NHS. And we're aware that there are a lot of considerations to take into account were we to go down that route. But what the alliance model or type of model does is ensure some support by commissioners to each individual provider, and that relationship with individual providers is kept going, and doesn't rely on one particular provider having to be the enforcer, if you like, as it would in a lead provider model. And basically, that's probably about as far as we've got. It doesn't sound very much, and there have been, I think, a lot of debate and discussion within the North about the different ways that we might actually develop this. But as I say, we are very much open to ideas now as to how we might take this forward.